Dr. Adams, and it's December 6, 2019, and I wanted to do another video in my series on COVID-19. I haven't done one in quite a while, mainly because I've had a number of patients expressing frustrations about various lockdowns, various masking requirements, and frankly about their businesses. I had a lady who runs a dog grooming business who is under severe economic distress because of the fact that the dog groomers were shut down for 2 weeks in New Mexico. I have another patient who's an accountant, and her business is suffering badly because she primarily serves small businesses, and those small businesses, of course, are going out of business due to the various shutdowns and the economic depression that has been brought on by COVID-19. So people have expressed a great deal of frustration about our response to this disease. And I just wanted to comment on a few statistics which are interesting and perhaps enlightening in relationship to COVID-19. First of all, I've seen a number of sources that dispute the increased death rates from COVID-19. And it's very possible that some of the death rates are overstated. The best way, however, to understand the impact of a pandemic like this is to look at the actual total death rates that have occurred during the course of the year and compare them to the expected death rate. So there's an expected range of death rates that we would normally see in a population. And, this ranges around 50 to 60,000 deaths per week on average. I have a chart here that starts in 2017 and goes through the middle of, goes through the first week in December, almost to the first week in December of 2020. And I have highlighted the expected death rate curve in blue ink from around April through the end of the chart, mainly because the printing resolution of this chart, it's really hard to see the curve on the grayscale if I didn't highlight it with a blue marker. And you can see there was a spike here during the winter of 2018 due to a worse than expected influenza year. So you can see that for several weeks in January in 2018, the expected death rate spiked above what they would normally see. You also see spikes here in 2017 due to influenza and spikes here in 2019 due to influenza. And you see an almost identical spike starting in the winter of 2020. And you would expect the curve to then come back down and follow that blue line that I put on there. But in fact, you can see that starting in early April, or actually at the very end of March, the last reporting period of March is March 28th, you can see that the death rates begin to spike. And they reach a point here where they're approximately 20,000 deaths per week above the expected number. So the expected number was around 55,000, and they had closer to something like 75 to 79,000 deaths. So about 20,000 above the expected curve. And that more or less, you can see that first spike. There was also a spike in the summer. That was a much lower level. That was about 10% above expectation. So if the average number of deaths per week was expected to be around 55,000 or so, it was closer to about 65,000. And then in the end of November, the expected number of the actual deaths compared to the expected number of deaths was about 10% higher. So it's interesting that there have been a couple of spikes, and we are seeing a renewed spike here towards the end of the year, but it's a much lower spike than you were seeing in April or in the middle of the summer. So the question is, why? Why is that happening? After all, the total numbers of reported cases have expanded dramatically. As of today, I think there were just under 15 million, like 14 million and 14.5 million or something like that, reported diagnosed positive cases of COVID-19. And according to the Centers for Disease Control, they estimate there's approximately at least a tenfold greater number of actual cases than reported cases. So what the CDC has done is they've looked at blood samples of people and they've tested them for antibodies, and they've found that there are roughly 10 times as many positive samples among blood samples for COVID-19 antibodies than reported cases in that given time period. So the estimate ranges from about a 6-fold to 26-fold, but the most reasonable number looks to be about a 10-fold increase. So you basically, whatever number you have of cases, 15 million is a nice round number, you've got to assume that there was about 150 million cases that have occurred in the wider population. We have a country of about 330 million people. So if at the low end we have 100 million cases, then that's about 30% of the population. 50% of the population would be right around 180 million cases. So, well, just under. But the point is that we're probably somewhere between 100 million and 150 million actual cases of coronavirus, most of which have resolved, most of which have passed without being diagnosed because they were mild. People had mild symptoms and did not go and get tested, which makes sense. If you have something that seems like allergies during allergy season, hay fever in September and October, people will commonly just ignore those kind of symptoms and say, well, it's hay fever. I always feel this way in September. So in Albuquerque, we have juniper season in February. So everybody wanders around in February with just a terrible runny nose. I see spikes of allergies in the late spring and the summer and the fall. So these people generally just mark those symptoms off as allergies, whereas a percentage of them no doubt have had COVID-19. That's important because certainly anyone who's had COVID-19 doesn't have an absolute immunity to getting COVID-19 again. I mean, we've certainly seen cases of people with recurrent COVID-19. There may be subtle changes in the virus or their immune response wanes or whatever. So that certainly does happen. But by and large, the vast majority of people who have developed this disease, and in fact, some interesting studies have correlated lower virulence or reduced symptoms with people who have had other coronaviruses. And remember, there's 4 or 5 other coronaviruses that cause the common cold that are floating around in society. So people who've recently had other coronavirus infections seem to have much milder symptoms with COVID-19. So the point is that these people, these whatever 100 million or 150 million people, whatever the number is, are going to be more resistant to COVID and much less likely to develop a second case of COVID and much less likely to be spreaders of COVID within the community. So the total population of people who have had COVID will reduce the spread of COVID within the community once their infection has resolved. So I don't want to minimize the fact that our hospitals are getting overwhelmed. I personally had my surgeries canceled for the foreseeable future by the University of New Mexico, who have said they're just not doing any elective surgeries because of the fact that their ICUs are overwhelmed, and they're actually turning the outpatient surgery facilities into ICU beds for COVID patients. So there is a severe pressure on our healthcare system. But as I showed with this chart, it's very intriguing that while there are excess death rates, even towards the end of November and the beginning of December, the spikes are not nearly as high as they were in April and in the summer. And I strongly suspect that several things are happening. I think that a younger population is spreading COVID right now, and therefore a population that's less likely to have fatal outcomes. Now, of course, there's respiratory and cardiovascular symptoms that may persist for months after coronavirus. So those kind of things are not to be ignored. But when it comes to the death rates, those things don't show up in the statistics. So if you have a younger population that is developing the disease, you will see a reduced death rate overall. And we are not at the point where we have achieved herd immunity, but we're getting a lot closer to where the coronavirus, with 100 to 150 million people, it has, a 1 in 3 or a 1 in 4 chance, as the virus is spreading, of hitting somebody who already has immunity to it. And so every time a person with relative immunity is exposed, they're not going to develop symptoms, they're not going to become spreaders. And so you will see a reduced rate over time. My personal estimate, which I can't prove to be true, is that by early January, we're going to see over 50% of the United States, in all likelihood, will have already been exposed to COVID-19. And very possibly by February, we may be hitting a point where over 70% of the nation has been exposed to COVID-19. At that point, we're going to see a statistical drop, I predict, in the rates of positive COVID-19 cases. I think we're going to see a drop in hospitalizations, and I think we're going to see a drop in mortality, where I'm not certain that we are actually seeing a drop in mortality here, but the current numbers are certainly not growing to the point where they were in April as far as excess mortality on a weekly basis. And again, I don't want to minimize COVID-19 in anybody's mind. I'm just trying to describe the way that the disease moves through a population, and the fact that we believe strongly that there is a large silent majority of cases that are not being identified with positive test results because they're not being tested. And that I suspect we're going to see a natural flattening of the death rate and hospitalizations due to the natural cycle of this disease. And of course, we're right at the verge where England has approved for emergency use at least one vaccine. It appears that the FDA is going to be reviewing and possibly approving the first vaccine by the end of the coming week, and possibly 2 vaccines by the end of the following week. There are, of course, distribution issues and concerns that are related to these vaccines. There's challenges because they have to be kept cold, and there may not be an adequate number of vaccines available for everybody to begin with. Probably not before May or even June will we have an adequate and excess number so that anybody who wants to wander into, say, Walgreens or CVS can go and get their vaccine at that point in time. So it will still be some supply chain issues. However, I strongly suspect that even before then, we're going to see a flattening of this curve just due to an increased population immunity to this disease. And if that is the case, then that hopefully that will reduce the total death rate as well. I've heard a couple of reports on the news which can be confusing. Yesterday I was flipping channels between the BBC and CNN for no particular reason, and CNN had an expert on who was talking about vaccinations and was sort of wringing their hands about the complexity of distribution and the fact that you really need at least 70% of the population. And studies indicate that 48% of the population may be suspect about taking a vaccine that's new and when they don't feel at risk because they're young or something. And he was expressing a lot of concerns about that. Interestingly, the expert on the BBC was actually explaining that we can prevent 90+% of the deaths by immunizing people above the age of 80 and by immunizing the at-risk population, people who are obese, people with diabetes, people with high blood pressure, people with other pre-existing conditions. And by immunizing those two populations, and he also felt that we should immunize healthcare workers because healthcare workers can be a source of spread to otherwise healthy people because, again, there's such a high percentage of asymptomatic cases that if you have an infected healthcare worker who doesn't know they're infected, they can spread it to, in all likelihood, more vulnerable people because healthcare workers are working with more vulnerable populations in general. But his feeling was that if you could immunize those populations, those older populations and at-risk populations, you could eliminate about 90% or more of the total deaths. And then by immunizing additional populations, people between the ages of 70 and 80, people between the ages of 60 and 70, people between the ages of 50 and 60, you get a diminishing return so that you've already covered 90% of the population who's vulnerable for a fatal outcome by immunizing this subset of individuals above the age of 80 and people with pre-existing conditions. And then you get a diminishing return with each subpopulation so that you get to a point where you don't actually possibly have to immunize 70% of the population. If you immunize the most vulnerable populations, you may reduce the overall death rate by 90%. Now, then, that still ignores those syndromes, those post-COVID syndromes, which I do not want to understate their importance. I mean, people are developing heart arrhythmias, people are developing chronic scarring to their lungs, pulmonary fibrosis, and other problems, and we don't know how long those side effects are going to last in populations. And of course, pulmonary fibrosis can lead to premature fatality, years or decades in the future. Heart arrhythmias can increase the risk of strokes years and even decades in the future. So, these are not things to be ignored or to be understated as their importance. But the point is, we might not have to actually vaccinate 70% of the population in order to significantly suppress the death rates from COVID-19. Now, we will have to vaccinate 70% of the population to eliminate all those post-COVID syndromic problems, which are also important. Interestingly, my own personal theory is that by the time the vaccine is readily available, we will already be at a point where probably 70% or more of the population will have been previously exposed to COVID. And it's possible that we will be at a phase where the curves are flattening naturally due to the natural life cycle of a pandemic. And remember, this is not at all the first pandemic we've had in the last century. There was a pandemic in 1895 of influenza, 1918, 1957, 1968, 2009. We kind of know the natural life cycle of pandemics, and they don't last forever. And this one certainly won't last forever. And it's very encouraging, of course, that we do now have some promising vaccines on the very near horizon. I hope that helps explain some of my thoughts about where we are with COVID-19 as of December 6, 2020. I will say again that nearly everything that I just said will be proven wrong in hindsight 3 months from now. But it's the best numbers I can come up with today, and I hope that provides some thoughts for you about COVID and where we are right now. I still encourage masking. I know that people get distracted by things like the Danish study, which were equivocal about masking, and other studies that have fallen on one side or the other. At the very least, I think there is a strong suggestion that masking will reduce the viral load that anybody receives. And there seems to be a dose-response relationship between the viral load and the severity of disease. And so through masking and hand washing and not touching your face, we can reduce the viral loads that people are receiving and very possibly induce a degree of immunity in the population without increasing dramatically our death rates. So I think that masking is a very low cost, very low technology intervention that may be of benefit and is almost certainly not proven to induce any harm, with the exception of a small percentage of people who have severe lung disease or some other, living at very high altitudes, that type of thing. And frankly, that subset of the population should be isolating at home anyway, because they're too high risk to be out in public where they should be wearing a mask anyway. So I hope that helps, and I wish everyone a safe and happy COVID season.